For me, I think the pillar stone and really the core of understanding patient satisfaction is understanding quality of vision. At the end of the day, that's really what it's all about, as David mentioned earlier. And to me, the eye trace is really a big part of that. And so what is the eye trace? It's a workhorse. I mean, it does everything from ray tracing, we'll get really into, of course, but it's a topographer, an autorefractor, does wavefront Ks, a pupillometer, provides us other factors such as angle alpha, angle kappa, the center of the pupil versus the center of the visual axis, et cetera, to know is a multifocal lens maybe the best option for that patient or not as well. The other thing that you're going to hear later on is the ability to educate patients. I found it so hard to educate what is astigmatism. How do you educate the patient so they understand the value? Well, what we can do also with this is say, okay, if I don't treat you for the astigmatism, just treat your nearsighted, farsighted, it's Mrs. Smith. And see on the left here, see how blurry that E is? Well, look what happens when I treat your astigmatism. It clears up all of a sudden. And that is a quick understanding for the patient why we need to address astigmatism. I can show the map down below here, say, look, that's where the eye is deepest. This is why we have to take care of it. So the education part of it, which you'll hear from other colleagues, is such a valuable part of the eye trace tool. For me, it was such a valuable tool. After using the eye trace in one office, we got it for a second office because it's such an invaluable tool. Every patient going through a cataract evaluation has to have the eye trace before, after surgery from a post-op perspective to understand how they're doing, especially if they're not happy.
Basically, this is like a Swiss Army knife in terms of diagnosis for the optical quality.
So this instills confidence when patients are unhappy. So if you find a patient who's unhappy following their surgery, empathize with them, tell them, we'll get to the bottom of this, we're here to help you, reach for the eye trace, put in a few lubricant drops, and then use their data and their simulations to separate corneal versus lens aberrations and assess IOL tilt and centration with the eye trace. So eye trace confidence, I like using the term eye trace confidence because it gives me confidence. It gives my patients confidence. The eye trace gives me confidence that my patient understands the issues. The eye trace provides objective data that fits the subjective experience of the patient. The eye trace gives the patient a voice. And the eye trace makes complex optics understandable. So you can see why I am very happy to speak about this device. I really regard the eye trace as a very senior colleague in my practice who knows a lot more than I do and can guide me when I'm not sure exactly what to do. So thank you for your attention.
I was really concerned that we were going to decrease this patient's overall quality of vision. So in all fairness, this is a case where the eye trace helped us to decide not to do a procedure that we thought we were going to do. In all fairness, in a refractive practice, sometimes that's just as important as doing the procedure. So I think without the eye trace, this would have been a very difficult thing to figure out.
So when I first got this in 2007 or 2008, I worked with Tracey because, as a cataract surgeon, I just want one sheet to look at. And so here is the cornea aberrations, and here's the internal aberrations. It could be the posterior capsule, it could be the cataract, it could be the vitreous. And then this is the total when you add the two together. And so this is the topography, obviously. And then we have refractions, we have refractive power, which Carolini will go over. But it's a snapshot of kind of where are the problems coming from. Let me just ask the panel, how many of you use the toric IOL check, and is it accurate enough that you don't even have to dilate the patient and look at their axis? Jesse?
We use it on most all of our post-operative toric patients. In all fairness, we're a busy practice, and once in a while somebody's seeing 20/20 and they sneak through. But that being said, it's even useful when we see that the lens is where it should be. It's nice confirmation for the patients. So we use it quite frequently. And again, not having to dilate the patient is a really nice thing.
Yeah, I think it's also important to realize by not having to dilate, you can walk into a room. So sometimes if I have a patient, like the text will tell me, yeah, patient may not be quite as happy. You look at the eye trace going before you go in there, and then you can kind of know what to say when you walk in, which is, I think it really arms you with that information before you talk to the patient.
How reliable is the eye trace refraction with the multifocal lens? Because many standard autorefractors don't work well with the multifocals. And this is a question from Switzerland. Anybody want to take that?
Yeah, it can be quite tricky. Mostly I find it quite accurate. It's certainly good on toricity, but it can be tricky. And you just need to use your manifest refraction in conjunction with it to help you make the decision.
We have another good question. How does the eye trace compare to the OPD, which also measures aberrations and separates internal and corneal?
I've used the OPD3 as well as the eye trace, as well as the Topcon KR1W, and they're all fantastic devices, do a similar thing. Why I really like the eye trace is the sequential laser beam, so I'm pretty sure that the wavefront is accurate. And what I really like, as Paul said earlier, is the educational aspect. The DLI is just so helpful. I find that an amazingly useful tool. So for me, it would still, of the three devices, be the one that would be my go-to.
Great.
And also with the eye trace, you can look at the wavefront. You can measure depth of focus curves. There's a lot of different functions and things that you can do, right? The OPD is just clear-cut cornea internal, but all the different functions with the eye trace, toric check, DOF curves, and again, you can use that to teach and show your patients and counsel your patients.
But I think these are excellent comments. I think regardless, just to be able to look at higher order aberrations, which is a way to look at visual quality and what kind of contrast the patient is getting, that is so empowering. And again, I just, looking back all the years practicing without this data, it's really, you're in the dark because you just can't see it in the cornea. At least the macula, I can see half of the time what the pathology is there. But you even look at a topography as we've shown today, and you don't always appreciate the imperfection from that.